Yes. Thank you so much. We are having nice time together. We are having moments for sharing our experiences and learning this palliative care concepts and on how best we can support our patients in their different endeavors as they are going through the journey of their conditions with their families. It's not an easy task, but we are hoping that we will be able to meet their needs as a team, and together we can achieve more. So that's what we are hoping to do. And let me say that we are also looking today to have another experience of achieving more and doing better. So I will say that there are things that I'm trying to sort here. Do you hear any echo that side? So today we'll be looking at how best we can facilitate family meetings, and we will be looking at how best. Good evening, Anita. It's great and nice to have you and your team here. And we will be looking at having a case presentation. You know, I like to bring fresh cases, and I'm hoping today's case will be interesting to all of us, and we will all come up with solutions, if not best interventions we can have to help these clients that we have. So, yeah. So I'm looking forward for that. Let me say that and give Mochona. So today we have Praise who will assist us with the presentation. So I don't know if you are set or you are still not set. What is this? We will have a presentation from Praise today. So, apologies, team. There's something I'm sorting with Praise. That is want to put the presentation so we can share it. So it is playing games with us. And I'm trying to, so we are going to have the presentation. It's a brief one, and then we will have the time to then have the case for today, which I hope will be interesting to all of us, and we are going to enjoy it, all of us, and I'm hoping we will all achieve the best for this case and be in a position to help this patient better. But one thing I can say that one of the things in psychosocial support, or when we are supporting patients, their families, it is very important that we include the family. And one of the things that we can use to include the family. One slide.
Thank you.
All right, so may I give this opportunity to praise and apologies for this technical disturbances. So we are going to have it now. I'm trying to put it on screen. And the praise will present it for us. I don't know if you can see the screen. I don't know, can you see the screen?
It's clear, Mr. Watlam. We can see it.
All right, we are almost there. What is happening? Give my title, give my title. We are trying to press to beam it to you. There's a small challenge here. Choose. There's nothing I'm going to touch. I will be scrolling for you. Yes, okay, we are ready. Maybe Mochona praise can continue now.
Good afternoon, team. My name is Praise Mochona, and I'm a social student from the University of Eswatini. Our topic for today will be about facilitating a family meeting. We'll be focusing on facilitating a family meeting. This presentation will cover why family meetings should be conducted. We'll also explain the benefits of family meetings in palliative care. We will identify who to invite for family meetings, discuss how to hold the meeting, the importance of cultural competence in family meetings, clarify where to hold the meeting and the length of family meetings, and lastly, to identify common mistakes to avoid during family meetings. I'll take you through our introduction. Family meetings are a wonderful but underutilized tool. These meetings promote respectful and sensitive delivery of information in timely, thorough, current, comprehensive, and accurate fashion. Patients may or may not attend depending on his or her condition, decision-making, capacity, and preference for involvement. You'll find out that a patient may be in a critical condition and therefore they can't attend the family meeting. And also when it comes to decision-making capacity, you find out that the patient may be a minor, therefore they may have little or lack of decision-making capacity. Family meetings help the family understand the disease process and options of care while providing the assurance that a plan is in place and everyone is working towards a consistent goal. It is crucial for families and friends to be aware of the patient's condition, of the prognosis and diagnosis. And we should also assure them that as clinicians, we are there to support them in making plans that are tailored to the patient's needs. Family meeting also provides clinicians an opportunity to collaboratively formulate a plan of care that is consistent with the goals and wishes of the patient and family. Clinicians and families collaborate in formulating care plans for the patients. We will delve into why we should hold family meetings. Supporting of carers is a core component of palliative care. To support and empower families, we also hold meetings to support and empower families to find their own solutions. We provide emotional support, we provide information and tools on how to take care of an ill family member. We also help them to be independent in making their own solutions. We also provide a safe environment for serious conversations and decisions. A family meeting should include a safe space for family members and friends to open up and to discuss serious issues. We also identify any available potential carers amongst the friends and the family. By identifying potential carers, the primary caregiver will be assisted and thus reducing the burden and distress on the primary caregiver. We also deal with specific problems. We also assess how everyone is doing. If a family member is ill, it also affects the other family members and friends. So we should also check on them, how they are doing, and if they need counseling and any resources. We will talk about benefits of conducting family meetings. There's family empowerment and support. I explained this in the previous slide that we empower families and friends to make their own solutions. We also provide resources and tools on how best they can take care of their family member, the ill family member. There's also information sharing and goals of care clarification. There's also enhancing the quality of care provision. Each and every family member have a role and responsibility. So if the work is shared amongst the family members, this will enhance the quality of care for the patient. Another benefit is to reduce caregiver distress and prepare family for caregiving. We also mitigate perception of unmet needs. We also improve bereavement outcomes. We offer grief loss counseling. We allow them to process their feelings and to support them and strengthen the bereaved family. Who to invite? With the consent of the patient, the following can be invited: family members, friends, caregiver, and palliative care team. These are the types of meetings that occur within the context of palliative care. There is bad news discussions, which we discussed at least weeks ago. There's also goals of care discussions. In the family meeting, we discuss how best the patient might want to be taken care of. We explore care preferences that are consistent for the patient. There's also advanced care planning meeting and bereavement session. Next, we'll discuss how to hold the meeting. There is pre-meeting planning, which number one says ensure clinician pre-meeting to assure consistency of message and process. It is advisable. It is advised for clinicians to discuss the patient's matters, and it also enables them to be on the same page about a patient, thus providing consistent information to that family. There is also clarifying goals of family meeting with patient, family, and staff. We also decide on the essential people to attend the meeting, for example, patient, family, and healthcare providers. Then after we look at the actual meeting, we arrange appropriate setting. We should, the family meeting should be in a setting, in a quiet setting and conducive setting. There's also introducing everyone in the room and relationship to the patient. The family members should they should be enlightened on what each and every person in that. They should be enlightened on the roles of the people during the family meeting. For example, the doctor, the social worker, the nurses, and so forth. We should also review goal of meeting. We should also elicit patient family understanding of care to death. Patients and families should understand the prognosis, diagnosis of the disease. We should also review current medical condition, attend to questions, review options for care, elicit response from patient if decisional, elicit response from family in terms of what patient will choose or him or herself if he or she will. This usually happens when the patient is in a critical condition. Therefore, the family meeting will still continue nonetheless, and the family will know what the patient would have liked. We'll also discuss the summary. We review the plan. If agreement, then we decide. If no agreement, then we make a follow-up. We'll also document meeting, who attended, what was discussed, and the plan. Documentation of the meeting is very important. It will help us in making future plans and future references. Next, we will look at the importance of cultural competence in family meetings. Cultural competence is one of the most crucial aspects when facilitating family meetings. Cultural competence is seen as the ability to understand, appreciate, and effectively interact with people from diverse cultures, which may include race, ethnicity, religion, sex, and so forth. We should also understand how cultural and religious beliefs influence decision-making in families. You find out that some people do not consider blood transfusion, amputation of body parts, and also organ donations. We should also encourage families to share the various cultural beliefs, norms, and communication styles. Cultural competence is a learning curve, and it requires us to adapt to different situations. These are the common mistakes to avoid during family meetings: debating the patient's medical status during the meeting, saving family meetings for crisis. Family meetings shouldn't only be held when a crisis, after a crisis has happened. It should also occur, they should also occur regularly. There's also going too far or off topic, turning meeting into a lecture and not documenting meeting minutes. If there's no documentation of the meeting, there won't be any evidence for future reference or follow up in the future. If we fail to document the meeting. And this is the end of our presentation. Any questions, answers, and comments?
Thank you. Thank you, Tim, so much praise. I hope colleagues we have been able to get such a wonderful presentation, short and straight to the point, emphasizing on the importance of holding family meetings. What I've picked from the presentation, one of the important things is that family meetings must be something we do regularly. It is true, we are from different settings, and sometimes other settings might not permit time for family meeting, but let's all strive to have those meetings wherever possible. And especially that now we know the instances where family meetings could be possible to conduct, especially on breaking bad news or when introducing certain change in the goals of care or when establishing the goals of care. It helps a lot. Actually, if you look at the first topic we did, when we are looking at psychosocial support, we covered the issue of interdisciplinary approach. And part of the interdisciplinary team, we are talking about the family and other relatives or loved ones and friends of the patient that we must involve. And we are in a context as in Africa, and I know also in India, where we find that patients value so much their culture and their families. So you will find that a patient will not make a certain decision and will leave it to the family, or will wait for the family to say some certain recommendations. And we have experienced, I hope all of us here, we have an experience whereby we will have a patient who will be enrolled to care or in our care. And then later you find that those patients, they end up losing the ability to make decisions or unable to even say a word, and then we have to rely on families. And most of the time, if our relationships and the goals of care between the clinical team and the patient are not the same, you will find that there will always be a clash and conflict. So for this reason, we are saying that part of the things we need to understand before we dive deeper into psychosocial support for patients and families is to understand that well, while we are providing psychosocial support, we will be engaging with the family most of the time. And we know one of the pillars of the patient, the immediate strong pillars are the family. And once the patient is sick, the patient's family gets sick too, because then the dynamics, the social context in the house changes, and you find that the family becomes unstable. And once the family becomes unstable, the family system has some cracks, and then the support and strength of the patient means it's crippled or it's at jeopardy. So one of the things she has also shared is the issue of being ready for the meeting. She has entailed that one of the things that is very important whenever you are thinking of conducting a family meeting is to be ready for that meeting, prepare for it, have all information, and if possible, engage the clinical team at all costs, so that we may agree on the direction that the clinical team is saying. There's nothing so painful that you will find that another clinician will say this, another clinician will say this, and the patient and the family, they end up getting confused. So it's very important that wherever possible, when we engage the family, we also conduct the clinical team, so that if ever there will be a need that you might need a companion, you plan for that. And also that we engage the family on those discussions. And I can say to share with you that indeed, when the family has been engaged for any meeting, they prepare for it and they come ready to share and learn, or to even share how they feel and what they think and ask those questions. But maybe for now, let me give the team the moment to add on the importance of having a successful meeting, family meeting, or add towards press presentation on how to hold a family meeting. If anyone wanna add something or have a comment or any question, I think at this point in time we can add to that. If you are not able to say it, maybe due to other issues, you can just leave the message on chat, so we can attend to that. Yes, I'm looking. Any comment concerning this? Even though the family meeting might sound as if it's a task or role of the social workers, as the term in top says, psychosocial support, or for the psychologists, but all of us clinicians, we have the responsibility to do family meetings whenever possible. And let's remember, they must be regular. It's not okay to go for a long time without engaging the families. You find that you have been taking care of this patient, the patient has been visiting the unit or has been in the ward for a longer time, but we haven't had time to discuss with the families. So it's very important to discuss with the families, because there are advanced care directives that must be discussed. There are goals of care that need to be discussed. There are news that needs to be broken. So we need to engage the family in over time and again. It helps them, it empowers them to feel in charge of the care of the patient and feel supported by the clinical team. So I was looking if I would see someone with a comment or someone saying anything concerning family meeting and in palliative care. But if then I don't see any hand, might not be able to see the hand again because of my setup today. Might not allow me to have access to the chats, but you can put your comment on chat. You can unmute and share what you are saying about family meeting. There are challenges that comes with family meeting. You will find that we need to have developed the communication skills on how to deal with difficult people. At some point, they will say to you, don't tell the patient this and that. Maybe you will be removing the hope. We need to understand how to hold don't tell scenarios. And also sometimes you'll find that there are those family members that will try to talk down the patient at some point in time, or they will try to talk down other people. So we need to understand how to hold those issues. I've understood that sometimes, in a family setup, those with the money are the ones that make decisions. And sometimes we find that those decisions are not what the patient will want, or those closer to the patient will want, but they will do it because they have an influence. So it's very important to understand the dynamics of your team or your group by the time, who is who and what's the role of those people. So it's not an easy task to do, but when we are doing it, we empower them and they end up trusting us. If they are not engaged, they will say that we kill the people, we are unable to do our job, we don't know what we are doing, because they don't know. what the patient are going. You find that some relatives, they think that this can be cured. Some have cultural, spiritual beliefs, which we will take as we go down. So yeah, those are the things you find along the way. But let me read. And as I say, oh, too bad I missed the entire presentation. Sorry, madam, you will get it in the IECO platform, it will be there. Yeah, today we have a poor network, even us here is not good. But you will get it. It will be there in IECO. Yeah, but all in all, we are trying to say, let's have family meetings. One of the issues, sometimes when we are breaking bad news, whether it's a failure treatment or whatever, we need to ask them, how do they take the different issues, and then will they need a family meeting? Or you will propose that it would be possible that we can have a family meeting to discuss your results or to discuss the outcome of the care, yeah. So it helps a lot because you find that some family members are not involved in the care because they are just in assumptions. Or you find that the client is in a position not aware how to tell them. I've attended one of the clients some days, I've now forgot. And then the client says that, you know what, my daughter here is aware that I have cancer, but is not aware that I'm also HIV positive. So I've hidden the other one, but I've disclosed the other one. So then we have to discuss and see how are we protecting her from other things than this. So sometimes family members, they want to tell, but they don't know how to say it. So it's very important. But let me jump to our case for today, and I'm hoping you will assist us with this case team. It's one of the difficult ones, but it may be easy for today. I'm happy I have Felicity here, I have Tandazile here, so I'm grateful we're gonna get some breakthroughs here. Can I put it here? So I will not be able to see the charts for now, but after the case, I will be able to see them again. So can I show you this case? I will just narrate what is happening here. So yesterday, I have an opportunity to enroll another client to home-based palliative care. So this was an elderly patient who is 54-year-old widow, and they was diagnosed with CA ovarian. So this woman, the concern that I have and the patient that has is that the client is diagnosed with CA ovarian, but staging not yet done. And now the patient has a problem of distended abdomen, and we are querying some mastitis already here, but we cannot confirm it as home-based palliative care because there are no tests done yet to confirm or evidence that is proving that to us. And then the patient, the challenge is that now that is diagnosed with CA ovarian, I think around May. The patient is unable to continue with the chemo due to lack of funds to pay for tests amounting to 150. And then also he heard about that in Manzini Government Hospital, she can get the test done for free, but she cannot afford to go to Manzini too. So what is happening with this patient is that this patient complains of severe pain, especially around the distended abdomen. So, and also she has moderate to severe anemia with an abdominal discharge. So what happened yesterday when we went there to admit this patient, we found that the other day she was from hospital, so she has get some other medication, and it was the other day, which is Monday, that she went to hospital with the hope that maybe she was due for cycle number 2 for chemo. But then when she reached hospital, she was told in Babani, she was told that then she needs to pay 250 for lab test investigations, I think. So because I found the lab form there, and also she has to pay 700, if not mistaken, for another test. She don't know what is it and what was it for, but I assumed maybe it was scan, I don't know. But she said that when they told her that, they said that she need to go get that money and do that. And then when she comes back, they will be able to continue with the chemo. But then unfortunately, when we reach home, we found her there frustrated, and she doesn't have that money they are looking for. Actually, she even disclosed that for her to go to Babana on Monday, she used money that was donated by a Good Samaritan to her. The Good Samaritan heard that she needs to go to hospital, then she donated the money to go there. Actually, she doesn't have money. So now she's so worried that she might end up not getting the treatment because she doesn't have the money for the test, because they said that the tests that are needed, they are not done in the hospital. They don't have, I don't know whether it's the reagents or what, but they said they could not do them, so she needs to go to the private and do them. So listen to what she said, the amount around 950 or so. That's our biggest concern now. What is going to happen? But then the pain is somatic and it's on the abdomen. It's not like it's internal. So she feels like when the stomach continues to distend, it's become so painful. So the pain, yesterday we found that she has tramadol. She was given 10 tablets of tramadol. So she has already brought down 3 because we came yesterday. She has been in hospital the other day. So we came and we found that she has done already 3 down, and she said it's working. And she said that the pain now ranges between 6 to 7, depending on what activity she's been doing. And the pain is always there. We found her sitting, basking on the sun, trying to cool the pain down. So the pain has been there since 7 months ago when she begins to experience the symptoms that she has been experiencing, often a distending abdomen. And she said that what makes it worse is when she has to do some walking around. And however, she feels that maybe after she has done the walk, whenever she sits down and sleep and have the family around to talk with her, it relieves him the stress and helps her not to think about the problems that she's facing now and have time to sleep and rest. So that one makes her feel a bit better. So the pain has made her to lose some functionality because now when we evaluated her, she is now ECOG 2, meaning that she cannot do any activities actually that require like going to cook, going to take some baths or getting some, just moving around and do things. She cannot do those lighter things. She depends wholly on the family to do things for her. Only what she can do is to sit down, eat, and then walk to wherever she needs to go to. But doing things with her hands and stuff, she cannot do that. And she's doing the tramadol. She said that it helps her a lot as we speak because it does relieve the pain. And then when we do the physical examination, I forgot to put it here, we found that the abdomen indeed is distended. She said that they went there, they did is it paracentesis or what? But there was no water that could come out of the abdomen. But the abdomen is continuing to grow, but no fluid could get out. So they stopped that. And he said that they did some surgery before, and then they do total hysterectomy. So when you look psychologically, the patient is moderate depressed, and the most aggravating factors at this point in time is her financial issues that she's going through. Remember, this is a widow and it's a 54-year-old woman without anything. Actually, when we called her in the morning, trying to visit, the only thing she requested, even not knowing us, she said that she doesn't have food. Sometimes it goes days without food. So can we help her with something to eat? Because appetite is open and big, so much so that he eats a lot, but then now the challenge is nothing to eat. And what worries her again is that she's eating so much, but the stomach is too big and he doesn't understand what is happening. And we couldn't explain much except that there might be a possibility of mastitis to her, which she said she understands, but we cannot confirm anything because no investigation that gave us that. And then also the other thing that may aggravate this stress and depression she's going through, it's the lack of family support. She's staying there with the family, but what we discovered is that this woman was married, but she never got any child in this family. And the husband also had a child outside, which is only one child, a lady she has, and the lady now has come to stay Lapana Kaigubu. And then we also have, the mama has a son, also whom she get outside marriage too. And then now, this daughter, I don't know whether stepdaughter, yeah, is not supporting her that much. And now she depends wholly on the son that he has, whom cannot stay in that home because that's not his home. So he stays there for some few days and then goes back. And she reported that that's the only pillar she has. And this son is not the one who's who will supplied, or he has the resources to take care of the mother, because now he's a low-income person who doesn't have a job. He hustles around to get food. At this point in time, then this son or this caregiver also is in a dilemma between staying with mama because mama feels comfortable when I'm here, but when I'm staying with mama, we both go hungry. So that's the situation that makes this woman get so hurt, because sometimes you feel that the grandchildren that are in the house sometimes doesn't even listen to her. Sometimes he finds herself alone and anguishing in isolation. So that's psychological what is affecting her. As I've mentioned, that has never worked in her life, has never gone to any school. She's very low class, very, very low. And marital status is widowed, not single. I don't know why I put single. Yeah. So when you look at this, I've mentioned the social issues, that he doesn't have children, has limited healthcare. So now it's dependent on the son who doesn't have enough strength to, because of the situation the patient is going through. And what he also mentioned is that even though he gets some community support in terms of those interested people who wants to visit her, they do come, and she feels good whenever some certain people have come and shared a scripture with her. But the challenge she has with people who visit her are that most of the people who come are the people who are staying those people who drink now and then again, and the perception she has about them is that whenever they are coming to visit her, they are not just coming to check on her and support her, they are just to check on her and go out and gossip about her. So she's not comfortable with them. And then, unfortunately, even though she has a church she used to go to, I will not mention the church, but I don't want to let down the church's name. But she said she used to go to this church, but unfortunately now she cannot go there. And she used to enjoy going to church because she felt that what was doing. But at this point in time, the church is not supporting her that much. And it hurts her a lot whenever some have come, they just come and not bring her anything that will help her, like food or anything. They just come and beat her and leave her like that way. Even though she appreciates to get a word from anyone, because the word of God is now in her pillar. And she believes that at this point in time, she perceives that the sickness she's going through, God is teaching her how to serve her in truth, because she feels like before she was not doing justice with God. So now at this point in time, God is teaching her a lesson on how to serve her in truth. Even though She said that she's willing to cling on God, even if death may find her. She will prefer that death might find her at her home. However, when we were discussing the advanced care plannings concerning that, she couldn't give us a clear statement. She felt like it's something she might be changing and not sure, but she would prefer to be home. So as I've mentioned, that she has been just diagnosed around 2 May, and then was done hysterectomy, and then it was done. She has started chemo already around May. So unfortunately now she is self-withdrawing because she cannot afford the funds to transport her to where she can get chemo. In Babane, she's scared now because she cannot go there because there are no results yet that they requested her to get, and he doesn't have the money they want from her. And she cannot go to Moneni because Moneni for now to her is far away. So those are the challenges she has now. So this is what she is in, ciprofloxacin, because she also has abnormal discharges, which we found on treatment already. So we are hoping it will go down because it was flagyl and cipro, and then on blood supplement, and then is Panadol and Tramadol, of which we did refill yesterday, and then the chemo. As I've mentioned that even though she has those priorities of care, but they are still not yet aligned very well, but she has them and she has those things she likes, and even the statements or the wishes she has concerning the future, she has. However, she still believes that God can still heal her from this, and she still has the hope that maybe if he could get the money to go and continue with the chemo, maybe she can be better. But unfortunately, we cannot do much in terms of the information of the prognosis because of the fact that even the staging and the scan, I think, is not yet done on her. So the challenge is that, whenever you are talking with her, she's really old now and does not understand the other concepts. So you have to explain need some time, explain other things. We cannot say that we have explained the diagnosis with her and we think she understands. Because when we talk with the granddaughter, the daughter told us, they said it's ovarian, but she said she does not know what she is suffering from. So even if they told her, she tends to not understand what they are telling her at hospital. So we need to have time to explain again and again to her. And we still don't believe we are done. We still to go back to her and check and see if we are in the same page with her while we are still waiting for the other test. So these were the hair vital signs. They were looking better and better. But the issues with that of pain and then the depression, which might be the depressed mood or the stress she's going through due to the finances. So what we are thinking we will be doing, and we are requesting you team to help us. That's why we are bringing this case to you. We are engaging you as our IDT here to see how best we can help this patient to deal with the solutions that are barriers now to access to the curative therapy. Which are the finances for the labs and other required tests that are required from them. If ever you can help us to see what best can we do at this moment in time. And also we are thinking of looking at the community she is with, because before we reach her yesterday, we have to ask someone along the way to say, where is this home? So, it's a known issue in the community that she is sick. So that's what we discovered yesterday. She is known that she is sick because they say the way we say it, they say, you want this home, so they know she is sick because she's an elderly person and she's known. So we think maybe because she is willing to get those Christians around to check on her. Unfortunately, she is disappointed that they are not doing their job to check on her, yet she feels their visitation and support, she will appreciate the treatment. So maybe the one can be considered, and also the counseling of the family and discussing the caregiving roles, because sometimes we find that the children, they're not aware what to do to support their grandmother. So we are looking around on that. and even engaging them to see the rift that is there between the stepmother and the stepdaughter. So maybe that one could help in addressing the caregiving issues at the family level. We are looking around on every time visiting her to engage on spiritual care, maybe reading scriptures for her and pray with her so that she can get the meaning. As she said, that one only give meaning to her, it's God. And then also maybe the social workers to look around also issues of the basic social needs, maybe thorough assessment of what really can this person be supported with going forward at this point in time. And also continue manage the distressing symptoms as they continue to show up. So that's what we are still looking for. And also engaging the family to, as we have mentioned it, for supportive care. So we have just enrolled her to care. So we are seeking for your advices and comments concerning this patient. Can I end there? So that's the case we are having and requesting you to support us and help us. How best can you support this person? How do we deal with people who are of this nature, having social issues, becoming barriers even to access? I don't know. But that's what she is, and she is so much hopeless because she really doesn't have the money to do that. I don't know, but at least now she's here. She heard that lab results, tests and stuff. Unfortunately, I didn't check what was ticked in the lab order sheet. There was what was ordered for her to do, but she was told it cannot be done in Malawi. So she must pay 250 to have those lab results done on her so that she can continue with the chemo. And then the 700 that they requested, but she doesn't know what is it for. But they also tell it was for another test, so and so. So just with the extent of the patient paying 700 and stuff in Baba, so I believe it was scale, I don't know. Yeah. So yeah, that's what we are. And I'm also worried because he's already taking tramadol. You know, these elderly people with tramadol sometimes it's tough, but that's what we have so far currently in the country. Yeah. Can I leave it with you, team? What can you advise us to do with this patient? Is there anything, or we just look on the supportive care and keep on giving her the hope that maybe she will end up finding the treatment? How does this chemo thing go? That you do one side, then you stay longer? I'm happy to take intensivists here because they are experiencing those things in oncology. I hope you got us, guys, and yeah. You will share from us. We are not unable to mute. Oh, okay. Let me see. I don't know why. Excuse, madam. I don't know why, you know. Let me see if I can do that here. Oh, I cannot do. Okay, but let me read the comment here so I can see the comment. Thank you for presenting. I think it is very important to conduct family meeting before initiating chemo treatment because defaulting treatment is very dangerous as it speeds up the cancer. My bubble. Cost of cancer investigation are now shouldered by family, such as CT scan report, no 710 parallel fund comes back to family pay. Family should be informed before initiating treatment so patients can be saved from drugs that can speed up the case. Thank you so much, Tandas. I hope it's an eyewitness. Thank you so much, Tandas, for sharing that. Yeah, that was the comment. Hey, so you mean now our client is at danger and before, which means now the blunder might, I don't want to say, as a health system, we've already put this client on danger. Because she did the chemo, I think, it's on May, not very far. She did one cycle. It was May, whether it was May 6th or so, I don't remember. She did one cycle though. And if you are saying that doing it and stopping it without completing my speed up the cancer, my goodness. But that's what is it. And thank you so much to share that Palliative these days is not shouldering them through. Now I understand that the 702 is for Palliative, for the CT scan. Actually, I was assuming when discussing it, I think, but now I'm 100% sure. Thank you so much, Andaza, to share that. It's very simple.
Hi, Mr. Matlang.
Yes, yes. Well, thank you so much, Felicity.
I've managed to troubleshoot here. Yeah, that wasn't me anyway. Thank you so much for the presentation. Unfortunately, I've been struggling with my reception this side, so I haven't been part of the presentation entirely. But at least the case, I managed to get a few cues. I think Felicity has quite highlighted it quite well here. I think we are having a series of issues from diagnosis, treatment, symptom management, pain management, and all.
Sure.
So I think our approach should be, I don't know, different from what we used to do, because I don't know, for some reason, I think we have been pro-curative than us being as objective as possible. Because currently what is happening in the country, I think what we are doing, we are giving chemo, and we know, would say, ideally we are supposed to be doing chemo radiation. Okay, that could be a discussion for another day. So, but what I'm trying to say is our approach was, we really need to start these clients on chemo without actually delving much into all the socio-economic issues, and actually considering, let's say, will this client be able to continue. From a test, like she has said, you find that even after managing to secure that 700, 800 for the contrast, they would still have to go pay for someone to analyze or to come up with the report. I understand they charge something like 750 per disc. So if it's 3 disc, then it's something like 2 point something. So at the end of the day, you are back to square one, you still have nothing. But moving forward to the issue of actually understanding diagnosis and everything, I think what we were trying to do, because we identified a number of gaps, we find that because of that approach that we're saying, we need to start them on treatment being the cytotoxic chemo drugs, and disregarding the palliation and counseling of it. So the approach what we are trying to take now is, let us sit these guys down so that they actually understand what is really happening. And when we are saying we're starting treatment, what is it exactly that we intend to achieve? Particularly because we're giving chemo and chemo alone mostly. So we are trying to take that approach. We had a meeting last week. We agreed, it's okay, particularly on the first day, when they come, let us not rush into anything, particularly starting with regards to starting the chemotherapy. Yeah. Let us sit them down and see how best can we actually approach in our care. Regarding the issue of yes, it is most likely to be ovarian cancer. It's just that I'm trying to figure out which client could be this one. It is most likely to be ovarian cancer because one of the symptoms, it's usually ascites, or if not ascites, it's just enlargement of lama internal organs. So if they try to tap, no matter how much they try to tap, if there is no free flowing fluid, then there's nothing that will come out. But you might find that it is actually issue of my organs that have been enlarged. So unfortunately, you cannot get into that as a counselor. It should be the doctors that are supposed to be giving that clear picture. So I would really want to believe that if the client comes back, then I think we'd have to see her, discuss with the doctors so that the client understands what is actually happening. because you might find that she's hoping that someday it will probably subside, but you might find that it's not going to happen that way. Yes, at this point, I think the best we can do is actually supportive care than us being bogged down by issues of chemotherapy and all that. It's unfortunately that the client has already started the chemo without them having a chance to say, with that information that you have given us, I choose to start the chemo despite everything else, or I choose to deal with the symptoms and see how far we can go. So I think we would really appreciate your assistance in this regard, because you might find that it will take time for them to come back to hospital. So the best shot will be supportive care as much as possible. I think we'll also try to furnish you with information if we get any. But unfortunately, you might find it would be difficult without the results. But if there is any information to the effect of, in terms of a prognosis and what to expect, then I think we would love to furnish you with that information, because you might find that the client is much comfortable being taken care of at home than having her move up and down, considering a number of issues. Otherwise, thank you.
Thank you, Thandazini. Actually, to add on your point is that I don't think you know Manzini, because with our discussions, like she has been in Barbara, because when we ask her, she mentioned she has a head about that Manzini. She can get chemo and the lab test and stuff, which might be for free. So I don't know if you have met her yet, but I hope in Babane, maybe Felicity, they have referred to her. She might be familiar with this old lady. Just for the purpose of ethical and confidential issues, we might not declare who she is here. But thank you so much, Felicity, for this. Actually, now I'm saying that, you know, family meeting indeed is a key, as Thandazini has mentioned, that we need to take them through. I hope one of the oncology steps will be engaging them and engaging the family members that the patient might be interested on a discussion before they agree on the therapy itself. And worse now, that they have to pay for the test itself, they have to pay for even the specialist to interpret it. As you are saying it now, remember another client who was saying now there's more money needed. I don't know how much it was. It's around what we are saying, but it was a referral from your facility though. And now I get why she was saying there's more thousands required now, but we are still working on getting so. Yeah. And it frustrates them so much, Thandazini. I hope you are in a good mood to say that we need to start with them, take them through what is going to happen and all the cost that it comes with and the things they need to do so they can make an informed decision before starting, because if then other drugs will make it run faster, we better not start it than start and stop. So I hope that one will help, because they will be able to see what to do and when, and understand the cost that comes with it along the way. Because sometimes they will do the test and you find an oncologist will then say, I need another test for review, and they'll be very angry and say that what test for, because we did it, because of the cost they are going through. And some will find that they are moving longer distances from the facilities, so they need to be prepared, because they end up defaulting, as you are saying. They end up defaulting. Like this one, she was then hospital Monday, hoping she would get another dose, but they couldn't give the dose because she's supposed to bring lab results that requires 250, the 700 for the scale, which she cannot afford, because even coming to hospital, it was a charity from someone else who said, oh, you want to go to hospital, let me give you this to go. So I hope if that one the team could do, but I hope at this moment in the country, IDT is not a choice actually, it's a must do. And thank you so much to offer that. Whenever we have something that we need to understand about certain patient, we will engage you. Especially once those guys that are saying that we are going to Manzini Hospital, it makes it easier to link them to, because we know you know them. But this one was saying Babane, but wished to go to Manzini. But unfortunately, money couldn't allow him. I don't know anyone else, team. This is the client that we are having. We will do that, and then we'll stick on the psychosocial. Actually, now we are giving us an information that what is really happening behind the scenes, so that we keep on sticking on that psychosocial. Actually, now we are trying to beef ourselves even in this moment of scarcity of morphine. We are trying to beef ourselves with tramadol as possible as we can, as an organization, to try cover the space, especially for those who are still taking up to 40 milligrams a day of morphine, to help them. For those who are exceeding, you know, the conversion, sometimes we find that even if you give them, it's not going to work. But with the combination of aggregates, we find that sometimes we are heading to somewhere and supporting them. So we are trying the best we can, even with the psychosocial issues, we are trying the best we can to support them. I don't know. Yeah, I have another client. I will not share.
Sorry,
Yes.
sorry, Mr. Mahlangu.
Yes.
I was wondering, I think this one will actually go back to the issue of a family meeting, but I'm thinking this is an elderly client we are talking about, and we are putting her through so much. I was wondering, did they consider doing probably an ultrasound scan just to see what is actually, particularly with regards to the abdominal distension? It is expected with ovarian cancers, yes, but just to see and give them a clear picture. It's okay, this is what is happening. Is it a fluid, or if it's not a fluid, what is actually happening, so that they can actually understand and appreciate what actually she's going through, other than waiting for the CT scan, for staging and all that.
I'm not sure the CT scan, because there were no papers that I could see there with from CT scan. The only thing she said that they tried to tamper, but there was no water, as we are saying. So yeah, then they gave it and say you must pay 700 for that scan. I don't know if it was like, but in her papers there was nothing like of a scan that I saw.
Ultrasound.
Yes,
Sorry,
I mean,
I'm referring to an ultrasound.
Yes, I mean ultrasound. I couldn't see
okay.
this diagram. There was no slip of that, unless I missed it. But there was nothing like that there. And then Sister Felicity is saying there's a need to enroll patients to palliative care diagnosis. This can help to conduct family meetings regular and find solutions in time, and also reduce false hope. Yeah, that's true, sister. We are hoping we will reach there as a country very soon than later, because the situation dictates that now, that we embrace it and put them through that. Because I have another client who have said that they have decided to stop taking palliative chemo because they feel like it's not doing anything for them, other than taking more of their money when they are traveling to take those chemo drugs. That's what they say. Yeah, so I think that's what I came. And thank you so much, Tandazin. I haven't seen it, but maybe when I get open to go there and see her again, I will do check again in the papers if they. But I remember that ultrasound comes with this nice black and white colored pictures, but I couldn't see that. Except that she told me taping was done, but there was no word. But what is frustrating at the abdomen is still good. But as I've mentioned, I couldn't say anything with specific because there was no documentation that I could base any type. But I told her that there might be other issues that are there, but the doctors might need to get that. Unfortunately, even if you say doctors, to her you mean transport, you mean all these fees, she cannot afford it all. But then we did indeed assured her of our support, regardless of the progress in terms of going to hospital and stuff. We'll support her with the best we can. I don't know. Yeah, this is one of the cases. So thank you so much, and I'm hoping that they will not miss other sessions with suffix, because in these days, if the cases will be presented by us, there are many challenges that will help us to balance between what is happening in the hospital setting, so that we may understand also when we are helping them. And we'll contact you whenever there's a need as a team for home base, so that we can help our clients going forward And thank you so much. I don't see any question here. And then that one means that maybe for family meeting, that will be the last thing we are doing for today. And may I emphasize, colleagues, that we keep on inviting other people to come. And let's try practice family meeting. It might not be easy. We might not have the time. We might not, the settings might sometimes not allow us to do that, but let's try to give that. Yes, Felicity is anything that we may think patient with patient. I hope Tando will attend today, but Tando missed the session, but he promised he will do join, but he has missed it. But yes, it's part of this IDT team that we have. And the next session, we will be looking at how best to do family needs assessment and support in palliative care. So we'll be looking at that, how to go about family needs assessment in palliative care, and then how to attend to those family needs. Even though we are looking at the patient part next session, which will be end of July, 31st of July, we will be looking at family needs assessment. How do we go about doing the assessment? This is Cyprian's number. But thank you. Yeah, thank you, Sister Felicity, for sharing the contact. Actually, we appreciate that. I hope it can help us. The navigators are doing a great job in the country, helping client access services as much as possible. So with that in mind, colleagues, let's meet on 31 July 2024, where we will be looking at how to go about family needs assessment, which will include that is not for the home base only, and also at hospital level, how can we troubleshoot the family needs so that while we are attending to the patient, we are cautious and how best we are supporting the family, because indeed, when the family is well supported, the patient will find the hope and strength to stand and continue fight until the end. Thank you so much, colleagues. Thank you so much, Tandazi, for joining. I hope you have joined with your team there. Please assist. There was a colleague from your facility who wanted to register, and I hope you have managed to do that. Please assist and request them to come. If there are social workers in our department, this is the moment we need them the most to be with us, so that they can come with these technical skills, the information they know, they join and share with the IDT, so we grow together. And thank you so much, Sister Felicity, for joining us today. We know you are a busy bee. Sometimes the network play games with you, and thank you so much for joining us. We are hoping we need to go together as a team. At this moment in time, multidisciplinary or teamwork is not a choice, it's mandatory. Otherwise, the system will push us until we are irrelevant to the people we are taking care of. So the best way is to work together as far as we can and embrace palliative care as early as possible at this point in time. Actually, from today's speech, I can learn that, you know what, without palliative care, the system is not going anywhere at this point in time. Actually, even before, even if all things are there, palliative care is the best. Thank you, team. Have a great day. Bye-bye.